Good morning, everyone, and welcome to the Ipswich and East Suffolk Clinical Commissioning Group's governing body meeting this morning. My name's Mark Shenton, GP Chair. And before we start the meat of the business, I'd just like to say a few things, if that's okay with everyone. Just in terms of giving some thoughts about our next steps, as hopefully we seem to be emerging from the effects of the pandemic that struck us over the last 18 months. So first thing to remember is all about that hand washing. Remember the happy days of happy birthday. Hand washing is still really important. Infection prevention and control has not gone away. We have our usual diseases to remember, and not all of them are amenable to the delight of alcohol gel on our hands. So hand washing is really still very important for those diseases like norovirus and E. coli, which can hit us very hard. So we mustn't forget those hard lessons that we learned early on in this pandemic, and we must remember the importance of hand hygiene. The next thing I wanted to talk about was about the vaccination success. Prevention is always better than cure. And I just wanted to say a big thank you on behalf of the CCG, on behalf of everyone, to those teams out there who've been doing an amazing job getting people vaccinated. If we remember back in the darkest times in January, in the middle of the most horrendous wave of COVID, the pressure that was on, the depth of despair for some people around that time, and the start of the vaccination programme and the plan that we had to get that coverage done has shown that it was the right plan, and many hundreds of thousands of vaccines, even over 1 million in our area, well over 1 million, have been now received safely. So thank you to everyone who's participated and doing all of that, many of them doing their other day job at the same time rather than instead, and a thank you to all of those hundreds of volunteers out there helping us get that sorted out. And so whilst we're pushing on to get that completeness of everyone who can have the vaccine getting it, we must remember that we shouldn't risk the principles that ensure all vaccination programs are successful. And that main principle is ensuring that public trust in vaccination is maintained. And anyone who's responsible for any decisions around compulsory vaccination, as an example, really, we must ensure that anything that's perceived as infringements on liberty, we've got to be careful that we avoid the potential of that being then making inequalities worse, because people worry about the intention of the programme and what it is there to do. And I just wanted to mention about the principles in public life, the Nolan principles, which serve us well, and decision makers who are having to make hard decisions around who should be vaccinated, how this will be done, what are the consequences, have to use those principles and be seen to use them. And for those of us, we're familiar with them. For those of us who aren't, their selflessness, integrity, objectivity, accountability, openness, honesty, and leadership. And we need to remember why they needed to be said out loud and written down. It was because there was a time where things were happening behind backs that actually shocked those who weren't aware of what was happening. And so those principles of public life are really important for decision makers and anyone who is in a position of trust with our public. And there is an equation for trust that I wanted to share with you that I think is meets a test, and it's integrity. Our personal integrity is our understanding of ourselves, but also the understanding of others and their reactions, what drives them, their motivations, and how we can work together. So that for me is about integrity. There's intent. What are we trying to achieve? What is the goal that we're doing? What want to gain? And how are we going to do that? There is the competence. Are we capable of doing this? Can we demonstrate our capability and competency? And that's, again, in the decision making, show you're working, and the ability to produce good results as a consequence of knowing what we want to do and how we want to do it. Can we demonstrate and make a plan into action? And I think it's just really important that as decision makers here around the governing body out there in public life, we can demonstrate that to our public and maintain trust. The next thing I wanted to talk about was our tolerance. And as services recover and attempt to meet all that pent up demand that's out there, be it shopping or eating out, going to clubs, or health and care, please be kind, please be tolerant. Staff in our practices and hospitals, our community services, voluntary sector, everyone out there are working really hard to meet your needs. But with demand at record levels, it is causing burnout. Some people are leaving. And in general practice, particularly our field, we can't afford to have people leaving. It's where the majority of our contactors, a population is made when we've got a health or a care need. And it's with good reason that we have practices that are local to people. But we've got less GPs than we had when we were promised 5,000 more. But our clinical teams are expanding. We've got help from our nursing colleagues, our paramedics, our physician associates, pharmacists and physios. So I ask you to please do what you can to help your practice meet your needs and that of your community. So if you can, please use the electronic forms, ring later in the day if you can, and accept appointments with our wider clinical professionals who are supported by us as GPs. We still need to keep practices a safe place for those who are vulnerable generally, but those who are vulnerable to COVID too. You know, the pandemic, it isn't over. We still need to ensure that we think of the hands, face and space. Call ahead so that we can space appointments to prevent overcrowding. Please ensure that you wear a face covering and ensure your hands are clean when you come to the practice. And I just wanted to talk a little bit about a tip on tolerance and on how we can help support each other and understand how we're all feeling. And it's something called neuro-linguistic programming. And I won't say that I'm a professional in this, but I have used this in my consultation techniques, and I would commend it and recommend it to any practitioner who's out there, be it in training or trained, any elected members, any journalist, anyone who interacts with our public. And NLP, neuro-linguistic programming, is really about us being sentient beings. We have feelings. But beyond that, we also can pick up the feelings of others. Remember a time when you were in front of someone who was feeling really anxious. How did that make you feel? It would make you feel anxious. If you were talking to someone who was really low, it would make you feel really low. So it's really understanding how we pick up feelings. But we're not just sentient, we're cognitive. We've got higher cognitive abilities. That means we can think. And so when we pick up feelings, we've got to then start thinking about how that person in front of us may be feeling. And rather than reacting to how they're feeling in a maybe negative way, a reflex action, instinct, can we take some time to think and apply that thinking so that we can help that person who's in front of us, or they can help us by giving them time to think and applying that thinking to how can we help them, not just pile in or react. Because the pandemic's not over, we're getting there. As a country, we've been really fortunate to be able to be in a position to develop, to procure, and have logistics available through publicly funded means to give everyone protection through vaccination. And again, I just want to thank everyone out there who's chosen to do this. And please, those of you who are still wondering, think about not just what's in it for you in putting yourself forward for a vaccination, but think what's in it for your family, for your friends, for your community. And just remember the joy we can have when we get together in reality. Can you remember those fantastic social occasions? We're starting to see them. I saw it firsthand at the weekend. We're social animals at heart, but we're social animals who want to help protect each other too. We're not just in it for ourselves. We want to protect each other too. So please, if you can, get vaccinated. Thank you. So I want to take us on into the business of the meeting now, and thank you for putting up with my thoughts. Joe, apologies for absence. I understand Lolly has given apologies. Do we have any others?
Yeah, the only other one was Badri.
Badri, okay. Yeah. Thank you, from Public Health. So any declarations of interest or any hospitality or gifts from anyone that wants to declare those over and above the declarations that we have put down? And nice to see them all as green. No? In which case, let's move to the minutes of the previous meeting on the 25th of May. Any issues with those minutes, either the content, accuracy, or otherwise? No, in which case they can be approved as a correct record. So if we can then move on to the action log. What I can see in the action log is all completed or pending September 2021. The completed one, we promised to send on some questions from Richard Squirrel, and I see a response has gone back to him as a consequence, and I'm assuming that he's happy with those, or if not, he'll come back to us, so we'll wait and see. We've not had any other response. No, Lisa, thank you. Okay, in which case shall we move to Ed and a general update?
Thank you, Chair. I'll compress my update because I think you've covered very eloquently some of the themes I may have touched upon, but a couple of things to add is firstly to note that Dame Claire Marks is stepping down as chair of the General Medical Council due to pancreatic cancer, which is very sad. Claire, as we know, is a long-term consultant at Ipswich Hospital at Esneft, and it is a great team in so many ways. She was the GMC was founded in 1858, and she was the first female chair of that institution. That gives you a measure of her leadership. So a very great person, and I think we would all, as a governing body, want to thank her for her national leadership and wish her all the best in the coming months. Secondly, we've had a change of Secretary of State for Health and Social Care since we last met. So we now have Sajid Javid as that Secretary of State. One of the first early decisions he's made is around the boundaries of integrated care systems, and there's a general movement to make them coterminous with upper tier local authorities, with some exceptions, and he's decided to make an exception for the ICSs in the east of England. So we will be moving forward on a Suffolk and North East Essex footprint in the coming months, ready for April 2022, where the CCGs will close and the majority of the CCG resource will move into a new NHS body called NHS Suffolk and North East Essex, and there will be a partnership committee formally established, which we already have for those partnership discussions. So very, very good to have that clarity. The Chief Medical Officer published a report last week on coastal communities, looking at the paradox of whilst coastal communities have great assets, great coastline, clean air, all sorts of advantages, they also often have very poor health outcomes and are often very deprived. So there's a big focus on coastal communities, and I think given Ipswich and East has a number of coastal communities itself, it's something we need to redouble efforts on, give some more focus on, I would argue, as part of our alliance work. And I know that we're very well placed to do that. And then Mark covered vaccination, but just to say that we've given two doses, two jabs to over 70% of our adults in Suffolk and North East Essex, and almost 85% have had one jab. So making very strong progress. Huge demands in the urgent care system, and we're seeing increasing numbers of COVID positive inpatients in our local hospitals, although the infection rate seems to be falling nationally in the last few days. And on elective care, we're making progress, reducing waiting time significantly, and our long waiters, but the overall waiting list is still growing. So a hell of a lot of work to do, and very much a long-term programme of work. So I'm happy to stop there and take any questions, Chair.
Thank you, Ed. Any questions for Ed? Yes, a lot happening all in a very short time. Imran.
Ed, just for clarity, Suffolk and North East Essex minus Waveney.
Correct, yeah.
Okay, so an unchanged boundary. Okay, thank you. In which case it's now time for us to move to our patient story. And I'd like to introduce you to Richard, who's come to tell us a bit about, or hopefully a lot about, what's been happening in the challenge of being able to give personalised care in complexity. And the what I'd like to do is just give a short précis, if that's okay, of information that you as governing body members have, and to invite Richard to give some colour to that and present us with some questions and challenges for us to consider and debate and look at how we meet the challenge that is unfortunately not a unique one. So I met Richard at the launch of the Integrated Care Academy, and I'd noticed that he had been attending the majority of the meetings, and I just took an opportunity to ask why. And he told me the story of what had been happening to him and his family. And the challenges that it was presenting him, and I invited him to come and talk to us as a governing body, to see what can we do, not just for this case, but for the many others that will be out there as a consequence of what's happening. And Richard and his family have had a very poor experience of health and care services in assisting his wife in her journey through to a diagnosis, the practical challenges that come with that, the consequences and cost, the heartache of that journey to a diagnosis, and then afterwards in meeting the needs of not just Richard's wife, but for Richard and his family, who will act as carers and advocates, as you would expect. And the effect and impact of this condition, its toll, with episodes of acute needs alongside that of what happens on a day-to-day basis, and the challenge of meeting those needs every day, all the time. And we know that these diagnoses will increase as the population grows older and bigger, and that diagnosis is dementia. It will disproportionately affect women, but we might not know that it also affects younger people who are also diagnosed, and how the system will need to respond differently if we are to be giving truly personalised, integrated care. And we've spoken already today about inclusion, and we're going to talk about it in our subsequent items as well. So how are we going to face the challenge that Richard and his family have been facing in terms of meeting the needs of personalisation with complexity, with multi-agency involvement, and try and make things simpler, more accessible, more understandable. So Richard, welcome.
Thank you very much.
And thank you for telling me your story. And I know that you've told many others, and you've told me how much you hope to try and make a difference as a consequence of the challenges that you faced, so that something can change. And that's why I so wanted you to come here and tell your story. So I'd be very pleased if you wanted to colour in the outline that I've given and pose those questions and challenges to us.
Thank you very much, and I trust you can hear me.
We can.
Mr. Chairman, governors, ladies and gentlemen, I'm very grateful for the opportunity to speak. And in particular, I'd like to thank Professor Shenton for asking me to fill this slot following a Teams call with him and Louise on Thursday, the 10th of June. I really am grateful. What is disappointing and unfortunate, of course, is that I'm unable to be with you all in person. As you'll know, I did ask for some documents to be circulated in the early part of last week, and I realised that they're not short. But as background, I felt that you should be aware of the dreadfully depressing absence of support my family and I have received since we moved to Suffolk just over 6 years ago. At almost every conceivable stage following her diagnosis with early onset Alzheimer's dementia and subsequent diagnoses with epilepsy and BPPV, all agencies who should provide support to people in vulnerable situations failed spectacularly. Collectively, there has been a monstrous display of incompetence and a wholesale absence of compassion. I'm conscious that there's limited time available, and to be as impactful as possible, therefore, I would like to concentrate on 3 themes. These are communications, leadership, and demeanour. And in doing so, I'll be providing examples from my wife's time in hospital as well as more general thoughts about the challenges that need a real concentration of minds, energy, and collective efforts to instigate essential systemic enhancements and eradicate the deficiencies that are so self-evident. So why communications, leadership, and demeanour? Well, some 39 years ago, after the Falkland Islands were successfully recovered, I had the singular privilege of being asked to lead the recruitment efforts for Royal Marines young officers. I homed in on the expression clear lower deck, which, as you probably know, is a term of naval origin. It remains an order for all hands to muster on deck so that the ship's captain can address them. It's a critical forum to ensure optimum communications, not least in very trying and testing circumstances. And as an aid memoir for these three key elements in the overall recruitment effort of the young officers, I opined that, for clear, concentrate on communications. Leadership, well, leadership is critical and there's no need for any amplification of this single noun. For deck, demeanour, in other words, how individuals present themselves. This is very important. And therefore, in lieu of clear lower deck, focus on communications, leadership, and demeanour. And I shall return to these shortly. But before developing my thoughts, I recently received the following from an editor of a prominent journal that concentrates on dementia. I quote verbatim, "Thank you for your email and accompanying documents. It's clear that you've gone through an appalling experience of dementia services. I'm very sorry to hear it. I agree with many of your comments and recommendations. It will probably come as little consolation if I say that so would many other commentators. Until social care is reformed and properly funded, I fear that poor experiences of dementia care, such as you and your wife have had, are set to continue. There are packets of good practice around the country, but this owes much to individual enterprise and leadership, rather than the kind of systemic approach that is needed." And I'd also pose the following question. I ask this of each of you very directly. If you, your other half, your partner, your next of kin, whoever was to receive the diagnosis of any form of dementia, what kind of service and support would you want and expect to receive from the various public bodies, along with the voluntary sector, who are both charged and responsible for reacting to such a difficult and traumatic diagnosis? What you will all know is that a diagnosis of a debilitating and degenerative brain disease for which there is no known cure is wholly devastating. When this is combined with the onset of a complex neurological condition, in my wife's case, epilepsy, that devastation increases substantially. And what we expected, we felt not unreasonably, in the light of these developments, was that the medical, adult, social service entities, along with the voluntary sector and others, would rally to the cause to provide comfort and support. But as you will have seen, however, for the first 2 years that we were in Suffolk, given the extraordinary reality of the abstruse, labyrinthine, contorted, even incomprehensible support landscape that is the reality of dementia support services, we were essentially ignored. For the first 2 years of life in this county, albeit I was collecting monthly prescriptions from primary care, there was no proactive consideration of our situation. And painfully, we were to discover that there is no defined pathway for dementia sufferers. Given the burgeoning challenges that the chair has just referred to, which are the reality of the explosive increase in positive diagnoses of dementia, the conspicuous absence of standard operating procedures to deliver appropriate services and support, it really beggars belief. Even though NICE guidelines, November Golf 97, entitled Dementia, Assessment, Management and Support for People Living with Dementia and Their Carers, clearly state that, inter alia, support should be, and I quote, tailored to their needs and preferences, provided in a format suitable for them, available from diagnosis and as needed after this. Yet for 2 years, nothing material happened. And as you will have read, legitimate benefits to which we were entitled were not forthcoming. And there is no mechanism for recovering these. So surely it's only appropriate to ask, how on earth can a dereliction of duty and care be possible in the public services in 21st century England? Why is there no robust, tried and tested process to ensure that all relevant agencies and efforts are conjoined in a coordinated and effective manner to react promptly and proactively to patients and their next of kin's needs? Where is the established leadership and management to provide for vulnerable patients' needs? Now, despite this grisly background, and since my wife's admission to hospital, I have been and I remain determined and resolute to try and be influential and a broker for essential systemic changes. That resolution has been, and it remains, to focus on process and leave personality issues to the flank. It's for others to name names if they feel that positive purposes can be served. So returning to the tenets of communication, leadership and demeanour, and based on the reality of my wife's 9-week stay in hospital, I ask you to bear in mind that having looked after her for many years, and literally having been her round-the-clock carer for around 5 years, before the emergency services had to be summoned, I was not, and nor am I to this day, under any illusion about the tragic reality of her declining situation. From the very first conversation that I had with hospital staff, I asked to be kept informed. She was, after all, admitted during a quite unprecedented pandemic. I could not have been clearer in saying that I was aware of the pressures. I did not want to be pestilential. I simply said, please keep me informed, not least as it was impossible to visit her. Crisp and clear communications, therefore, should surely have been the order of the day. But the reality was quite the reverse, and it pains me to have to summarize as follows. That in 65 days on a hospital ward, there were just 5 calls from medical staff, one of these from a doctor. The others were from one of the consultants. The second consultant did not call me. The only calls from ward staff were to advise that my wife required a COVID test, to advise that she'd been found on the floor during the night and due process was being followed, and to ask about some of her dietary preferences. Communications that I did not receive included inputs from the second consultant. The result of her COVID test. She was in fact COVID positive, and I only found this out when I telephoned in the order of 6 hours after her positive test result. Now, surely I should have been told that she was COVID positive as soon as this was known. A meaningful commentary on her weight loss. It was only following discharge and admission to the specialist unit that I learned that her weight had reduced by something approaching 15%. That's 15% in only 9 weeks. Observations about the severe decline of her posture. It is both indisputable and undeniable that between her emergency admission to hospital and her discharge in that 9 weeks, that her posture changed from being essentially upright to one that, on admission to the specialist unit, was described to me over the telephone on the second day that she was there as, quote, severe, if not chronic, scoliosis, unquote. You can imagine how shocking it was to hear this. Now, whilst I could expand on the above, I suggest that these facts and their veracity really should not be challenged, but they speak for themselves. They point to a remarkably thoughtless character of general communications, and I find this hard to comprehend. Specifically, in terms of continuing healthcare, and with much regret, I need to highlight the following. Discharge to a CHC placement was confirmed on the 21st of December last year. Yet initial contact by CHC did not happen for 3 days until Christmas Eve. The holiday leave period was just beginning. CHC confirmed its absence on leave until the new year, but affirmed that efforts to secure an appropriate placement would continue. The next contact with CHC was on the 5th of January, and therefore a gap of 12 days. Essentially, there had been no progress, except to confirm that no local placements could be found, and the best outlook seemed a specialist neurological care centre some 100 miles from home. On the 7th of January, I was advised by CHC that my wife's name was, quote, on a bed, unquote, at this specialist centre. It was confirmed to me that this could not be offered to anyone else. On the 12th of January, and thus 5 days later, CHC confirmed that admission to the specialist unit was unlikely before the 18th of January. In a follow-up call, CHC then propounded a temporary fix whereby my wife might, pro tem, be looked after at home with full-time carers pending her admission to the specialist unit. I'm bound to repeat a question I've already asked. How could such an insensitive proposal be even considered or presented? On the 15th of January, CHC confirmed that the place at the specialist unit had been confirmed. Now, this was the last contact for 6 days until the 21st of January. And in the interim, routine conversations with ward staff repeatedly indicated that discharge was set for the 21st of January. On the 20th of January, the ward, not CHC, but the ward, advised that transfer to the specialist unit had been delayed until the 27th of January. I therefore attempted to telephone CHC, but there was no response, and in lieu, I emailed them to try and obtain their update. The following day, and in response, CHC stated that in fact discharge on the 21st of January had never been an option, But this was the consistent message I'd received from the ward. A subsequent telephone call from CHC then apologised for their lack of contact and indicated that this was because their telephone system had been broken down and unusable for several days. And I've hardly heard a more lame excuse in terms of not addressing a serious situation, and I'll avoid further comment on that. On the 25th of January, in the final contact from CHC, and the call was from a personal mobile phone, although apparently this is contrary to policy, the use of personal phones, the arrangements for the move on the 27th were confirmed. Sadly, the reality is that my wife had been in the wrong place for at least 5 weeks. She had been a bed blocker, and she'd not received the care and attention she needed for several weeks. It's hard not to contend that medical reaction to her dramatic weight loss and change of posture was some way below acceptable professional norms and standards. Following admission to the specialist facility, it was readily apparent that there had been potentially serious failings in terms of communications by, particularly, medical staff and CHC. Management of my expectations and those of our son were appallingly awry. And I put it to you that to comment otherwise would be to defend the indefensible and would in fact be the epitome of disingenuity. In drawing your attention to these deficiencies, there is a very good connection to leadership, the second and vital strand I mentioned earlier. Questions that immediately arise. Who is responsible and accountable for ensuring that reasonable and adequate communications are a hallmark of interactions between the likes of medical services, patients, and their next of kin? Who is responsible for ensuring that there is a culture of sensitivity and commitment to ensure that, especially for those facing vulnerable and challenging crises, expectations are managed as a result of timely, informative, and helpful messaging? Who has overall responsibility for ensuring that there is a true culture and delivery of patient centricity. And if I may coin a phrase, and perhaps more importantly, and in extremis, who is the designated leader whose leadership and example ensures that management of patient expectations, a range of inevitable and changing pressures notwithstanding, really are the key drivers for all involved? Clearly, there is considerable scope for leadership development. It is sorely needed. After communications and leadership, I highlighted demeanour, a combination of outward bearing and behaviour. Demeanour is not a quality that should be considered in isolation. For whilst it should be relatively simple for someone to look smart and look the part, ethological elements readily combine and with communications and leadership. It is high and ever-improving standards of these combined that patients and their close families need to see and have a right to expect. There is, however, a considerable distance to travel. I repeat that I have no desire to get involved in name calling, and I will not do this. And therefore, I've added in the following the phrase, the consultant, to maintain appropriate neutrality. In reacting to my formal complaint to the hospital, it was both surprising and disappointing to see that the official response included the following comments. I am very sorry. Recognizing the shock and distress you have articulated, the medical team have offered their apologies. The consultant has apologized that updates were not provided. We can only apologize that you had to ring in. The consultant confirms that after a period of reflection, there was a breakdown in communication. The consultant has reflected again and learned from the situation. The consultant has identified a degree of passivity on behalf of the medical team and sincerely apologizes again. Another consultant led on communications, which your wife was happy with. The consultant confirmed that your wife was not displaying any signs of astute posture. The consultant has reiterated that never any signs of astute posture on medical review and did not see an interval change in her posture. Then later, thoracic scoliosis was identified in a chest x-ray. But she, that is my wife, was unable to complete exercises due to her cognitive abilities. We accept that staff need to be more specific about proposed and actual discharge dates. Now, one point that I must take very strong issue with is the notion that my wife was happy with the communications processes. The statement is utterly risible, and it is in no way possessed of reality. In the same letter, albeit in another context, her cognitive abilities are clearly questioned. If this kind of reaction is redolent of responses to formal complaints, then, ladies and gentlemen, I am truly troubled. Alas, the response singularly fails to provide adequate rationale about my wife's deteriorating posture. I provided photographic evidence of her physical appearance just 4 days before her admission to hospital. And I've since learned that on the 6th of January, in a pre-admission discussion between the hospital and the specialist unit, mention was made of, quote, a mild osteoporosis stoop, unquote. That's 3 weeks before her discharge from hospital. The commentary about her postural decline is therefore unacceptable, and as a result, precious time, energy and effort must be consumed to obtain an answer possessed of honesty and integrity, and this really should be unnecessary. I cannot offer any objective reason for the shortcomings in this official response, not least as towards the end of the letter, it is stated that, quote, genuinely listening to our patients' experience of care is extremely important to us, and learning from where we could have done better is a cornerstone to our journey to continuous improvement. I suggest that a paradigm upward shift in leadership is urgently needed. And this has been a common theme in much of the work that I've undertaken in the last 6 months. For information, today is precisely 6 calendar months since my wife was transferred from Ipswich Hospital to the Specialist Neurological Care Centre, 100 miles from home. And for me to go there is a minimum round trip of 5 hours, which I do every 4 or 5 days. Further, it is 35 weeks to the day, and therefore 245 days since she was admitted as an emergency to Ipswich Hospital. And since I started working on this, as you will have seen, I've made direct contact with over 40 individuals who have a connection to, and I submit a responsibility for aspects of dementia care and support in Suffolk. I've had around 50 team calls and more are scheduled. I've made a series of recommendations with a view to achieving some quick hits, but so far it appears that the will and determination and therefore the leadership to make things happen is lacking, which is disappointing. And further, it has been a surprise to me that some of those I've contacted, including a few in senior positions, have not responded. It really is leadership that is needed. And for dementia services and support and all this entails, in a recent note to the Mental Health Trust governors that I was asked to submit, I argued that such leadership should be robust and independent. It should have open, direct and full access to all agencies and individuals who have a part to play in improving the situation, but not limited to the likes of the plethora of medical entities, which include hospital trusts, mental health trusts, AAT, IDT, clinical commissioning groups, CHC, primary care. Then there's adult services, the charitable sector, academia, for example, the ICA. To use a military analogy, and I've said this in a paper I have sent you, to me there is a paramount need for dementia services for a captain on the bridge. Not a committee, but a captain on the bridge. The overall situation does need urgent consideration, and the key driver should be a combination of the patient, their next of kin, and carer. And therefore, the critical questions are why, given the exponential increase of dementia diagnoses that have been projected, has such a critical leadership matter been overlooked? Who is the individual in the county that is ultimately responsible for leading and driving efforts to improve dementia services? In his outstanding book, Being Mortal, Illness, Medicine, and What Matters in the End, a colleague of the author, Atul Gawande, who was overseeing seminal changes in a care setting, commented that, quote, culture has tremendous inertia. That's why it's culture. It works because it lasts. Culture strangles innovation in the crib. And I urge you to reflect very carefully on this wisdom. As a final thought, may I challenge you to invite me back within a maximum of 6 months to outline how, hopefully dramatic measures have been taken to ensure that situations such as my wife and my family have had to endure have been consigned to the history books. We should all be troubled by the abhorrent realities that are bound to be extant for the likes of Mr. and Mrs. Miggins, pensioners with minimal income, no access to the internet, living in a bucolic or rural setting with poor telephone signals and maybe a lack of motor transport. I cannot change what so far has been cast on us. I can, however, do my best to champion better services and support for others. Ladies and gentlemen, I'm very grateful for your time. I thank you so much for listening, and I hope that I might have made a useful contribution. Thank you very much.
Thank you, Richard, and thank you for your leadership in this and the way that you present your insights and challenges. And I've taken a number of notes around particularly the leadership culture and what true leadership and good culture means in terms of making change happen for the better, and not accepting poor practice and not accepting poor outcomes. And the piece around systemic is really important to me personally, around not being reliant on individual enterprise, as your quote was, or people having to be heroes in order to get what they need, as just what should be expected. And the issue of what experience would we wish to have, you know, it is a social thing, isn't it? If we are not prepared to accept that, why should anybody else be prepared to accept that? The proactive approach, don't accept second best and poor. Think, what is it that we have to do to make that better? And we all have a responsibility to that, from this level of the board through to the front line, if we call it that, the frontline team who are doing those interactions and giving them the trust to apply their professional standard and not accept that professional standards should be lowered because the culture is not right. And the challenge of cultural change is a personal challenge that I am wanting to take forward in the Integrated Care Academy, but not in the Integrated Care Academy, but out there, and to say, this is what we need to do if we are to make leadership real and to make our plans real and meaningful for people, that actually we've got to think like people. We're humans, we have our social interactions, and we have our what matters to me that we need to meet if we're going to meet the personalized agenda that is so important. And the invitation to come back in 6 months, yes.
Thank you.
Set a challenge, we'll accept that challenge. Lisa.
Thank you, Richard. Thank you. I'm Lisa Knobles. I'm the Director of Nursing for Suffolk and North East Essex CCGs. I mean, there's just so many challenges that you've given us and so much to think about. But it kind of really illuminates a point for me, which is about the only people that really see the totality of our services is the patient and their family. We are so used to looking at services in silos, really. So how does somebody experience Ipswich Hospital? How does somebody experience CHC? How does somebody experience different parts of the services that we commission and the services that provide care in a whole range of people? And it's only when we listen to families and patients and understand how that all joins up, and the accumulation of poor communication and leadership and all those things, and the impact that aggregation of experience makes on somebody is significant. And if it's the sum is so much more than the individual parts, and that's what we want to try and, well, we will do going forward, is very much looking and understanding people's experience of the whole rather than individual parts, because it's so much more important to understand how your wife has experienced the whole rather than just Ipswich Hospital or just CHC. That's important as well, of course it is, and there's things that needs to be addressed within those individual parts of it, but you've really just highlighted for me that listening to people's experiences of the whole, I hate the word journey, but I can't think of anything else, is really important. Thank you.
Imran.
Thank you, Mark. And Richard, thank you for sharing those experiences. That can't be easy. I'm very minded that for us to embed culture change and for us to truly get to personalised care, we have to take the principles of true co-production, which is co-production from thought inception right the way through to then action and management of the cases. How do we expect to provide truly personalised care if we're not co-producing with our system partners, and more importantly, our patients and the residents of Suffolk? So as a key principle of moving forwards, we have to be able to co-produce with families, with patients, and do it in a meaningful way where they're not only the supporters of change, but then also helping us to police the system, because otherwise the lived experience that we talk about, it gets lost in numbers and it gets lost in targets and various things. And we have to remember that lived experience is really the marker that we should be setting ourselves by. So our markers of success should be stories, unfortunately not like Richard's, but telling us how things have got better, not numbers on a page and statistical analysis. So that's just my bit, Richard.
Thank you, Imran. Lorna.
Thank you, Richard. One of the things that really concerns me is it's not just going to be in dementia, it's going to be across the board in many of the conditions that bridge both acute care, acute admissions, going to the main trust and then coming out into the social care system. And that, for all those conditions, I think that we've got a problem. We've got a lack of a conductor. We've got a lack of a person who can navigate the system effectively and be a single port of call for families and the patients. And we know that if you're in the system, if you're working the system, that you've got a much greater chance of getting hold of the right people. And that shouldn't be the case. It should be that there should always be a champion there for you who can navigate you through quickly and stop duplication and cut the cost in terms of those sorts of things and try to smooth the journey, which would actually be a win in terms of efficiency, a win for the patient, and improve the culture and make people feel things are moving in a straightforward way. You know, I think there are so many areas that we need to sort that out of. I mean, it's just exhausting to listen to Richard's story. Really exhausting.
Thank you, Lorna. You're using that NLP today. Richard Watson.
Hi, Richard. Richard Watson, Director of Strategy and Transformation for the Commissioning Groups. Firstly, I'm very, on a personal level, I read through everything last night, and thank you for putting it into the level of detail you have, because I think it's really helpful. I've never seen it laid out in that way before, the kind of chronology over many years of someone's lived experience. And I think it really points, as Lisa said, to the importance of how we absolutely need to do much more than we're already doing in terms of involving those with lived experience who can truly understand the whole model, the whole way in which you're experiencing services. You asked early on about what kind of service would you expect to receive if you had a family member going through. We do, nowhere near the same level of degree that you're going through, Richard, but I would absolutely resonate with what you're asking for is what we should all expect in terms of the approach to our loved ones when they're in need of joined up care. And I think we've got a huge way to go to truly find a way of joining up our services so that they are much better at the point of need for our loved ones. There's two things. I know you've been talking to Rob within my team around how you can absolutely support us with finding the answers to that. Indeed, some of the quick wins you've set out, I think, are things that we're absolutely wanting to look at. I just wanted to focus on two elements. I think the first is the support services wrapping around those who may have or have dementia and their families. So, as you'll know, Richard and the board, we commissioned about 3 years ago Sue Ryder to provide the Dementia Together service, and there's an opportunity to reflect on that service and how we might enhance it through the procurement exercise that we'll be launching. And I understand that you've accepted an invitation to join that process, which I would welcome, and actually having more people with lived experience to continue to redesign what that wider support offer would look like to those who may have or have dementia in their families. So welcome your ongoing involvement in that as we can shape, I think, further what that wraparound support looks like, and particularly that coordination role, which I think one of your recommendations is suggesting. Absolutely agree with that. Again, from personal experience, that would make a huge, and is making a difference. And the second one, which I think resonates with your leadership point in part, is the Dementia Action Board that has been pulled together. Now, I think we'll need to look at the word action and make sure that it is action, not words. So I think there's more work we'll need to do on reflecting on the board that's been set up around dementia, the leadership of that, and actually the programme of work that is being embarked on. And I would, I think you've already agreed on this, but I would strongly encourage your active involvement, I'm sure it will, in that, because again, I think when we may be drifting off into elements that may take a long time, although some of that is important, I think it's really important to come back around what it actually means for those on the coalface of experiencing these services you and Lisa have alluded to. So I do think the action board is the place where we can start to try and address collectively how we address some of the innate issues that you've outlined. But I do think we probably, on reflection, need to take another look at that and understand, is that the right setup? Have we got the right people? Have we got the right leadership involved in that? And then finally, I think if you look nationally, where there's a particular issue, not saying this should be done for everything, there's a czar or a champion. They bring in someone who is going to look at this. It might be something that we want to do for Suffolk. So would we, as a set of public sector leaders, look at actually having a champion or someone who actually can work across services around this? So I think there's food for thought, Richard, in what you've outlined, and I welcome further conversations with you offline in terms of some of this. Thank you.
Richard, did you want to come back?
I'd just like to say that I have very specifically used the term Tsar. I've used other terms, the guru, almoner. I reflect on what was done for cancer some years ago when it was all over the place. And I think it was a worthy oncological professor, I've forgotten his name, but I know eventually he was knighted, and he was the first cancer Tsar. And frankly, the analogy of what he achieved is exactly the way that dementia support services, and as the good lady from Norfolk said earlier, Lorna, yes, it's not just dementia, there are other equally demanding, perhaps even more demanding situations. But it is that central focus that is, the person who is applied to that job, and I'm sorry to get military again, but they need epaulets of Velcro, not Teflon. So I would strongly support that, and anything that I can do to try and assist in that process, please let me know.
Thank you. Steve.
Yeah, thank you. Richard, my name's Steve. I am a lay member of this board. I am an ex-military engineer, 20 years in the RAF, involved in the Falklands, the first Gulf. I then retired, led a large manufacturing business in Ipswich, and then retired from that and joined this worthy group. And one of the reasons, and this is the first time I have said this in front of this group, Richard, one of the reasons I did that was because I thought the NHS was crap and it needed people like me to help it. And forgive me, team, and I'm kind of choking up when I'm saying this. I don't have this sort of speech in front of people. People know that from me. My opinion of the NHS in the first year, I think, of being in the CCG, changed 180 degrees. Everywhere I was involved, I saw people doing their very best. I saw people with great humanity. I saw people just struggling against bureaucracy, but I saw people who were people in every aspect of the CCG and its various connectivity with other organisations. And then, very much like you in a way, my wife, when I say she'll kill me for that, my mother was diagnosed with dementia, and I read your journey, and it's word for word very similar to what my mother went through, but rather than epilepsy, it was Parkinson's for her. But literally, with the delirium, everything that you explained, I thought, been there, done that. But again, I but I didn't recognise a lot of what you said. And I'm not mindlessly defending these people, but I found people who, yes, there were processes that were all over the place. There was lack of communication between social care and the medical side sometimes, but I saw people trying to do their best all the way through. And I think we can, my team here get beaten up a lot, and I'm asking my opportunity, Richard, you've had your opportunity. My opportunity is to remind my people that most of the people out there are doing their bloody best. And please, we have to listen to people like Richard. I get that. I really do get that. Because again, as my people know here, about 18 months ago, I was diagnosed with bone cancer. I've just come into remission. Again, I went through a very hard process with Ipswich Hospital and various other people. But, you know, here I am out again, happy and a little bit achy in the back, but not at all well. And I met some great people and I met some crap people. It's the bell curve.
Yeah.
You know, you get good people, you get bloody marvellous people, and you get monsters. And the vast majority of us sit in the middle there. So, Richard, I hear what you say. There is a lot to be done, and particularly in dementia, and I continue to be a carer for my mother. She's just next door. But I asked my team, don't get ground down. You know, you are good people, and it's a mixture of knowledge from people like Richard and your basic humanity. Sorry.
And Steve, please, you know, the reason I invited Richard to come and talk to us was not to grind people down or to, that is not an intention. It is a definite express non-intention of Richard to do that. It is to show, I think, as Lisa put it, the understanding of the holistic experience and the impact. And, you know, as practitioners, that is our challenge. You know, that is the challenge that we aspire to. We don't want to deflect our way from that. We want to rise to that challenge. And there's an old Deming quotation of, it's not good enough to work hard. First, we must know what to do and then work hard. And this description is helping us do that, because the worst thing in the world is to come to work, to do a job and think, God, did I really make a difference or not? We want to make that difference. Yep. And as humans who come into this humanity space to do good, the worst thing in the world for us is to then face all the things that say, I can't do that, you can't do that, you can't do that. Well, hang on, where is my ability to display and deploy the standard of care that I want to give, that I want to be there for that individual and the context of their family and the community in which they live? That's why we become GPs, is why any of us go into those professions that have got health and care with them. And the last thing we need to do is beat the hell out of people's ability to do good. And so, you know, I hear what you say, Steve, but I really think that as a team, we can do this. The ICS says can do health and care. Therefore, let's do it. Let's make those changes. Let's put that focus on culture, you know, because actually people want the good culture. They don't want the bad. It's very easy to remain in the good culture, as Richard said, strangling the innovation, strangling the standard that we want to bring in. Maddie and Ed.
Thank you, and thank you, Richard. In a couple of items' time, I'm going to present the Alliance's delivery plan for the coming year. And I don't know whether you'll be able to stay for that or not, but I just wanted to have the opportunity to say that if we peel back all of the Alliance's delivery plan, if you look at it as a stick of rock, what our goal is to join up care for individuals and to enable staff to do that. And I think that your story, the experience of your family, shows me today why that is so important. I think Richard's described some specifics. Lorna's talked more broadly about how we need to learn, not only in terms of dementia services, but many others in joining up care, joining up teams. And you will see that is absolutely the intent of the plan. And fundamental to that is one team, which Mark speaks so passionately about, and the journey that we're on, so that it's not just across Suffolk or across Ipswich and East Suffolk, but it's within our local communities that social care colleagues, community nurses, and the voluntary sector and others are able to join up to meet the needs of individuals. So I just wanted to say that in case you were unable to stay for that item. But please know that is absolutely at the heart of what we want to achieve. Thank you.
And, you know, I couldn't give a monkey's what we call ourselves from a Ipswich and East perspective, or a Suffolk and North East Essex this, or reforming structures does not cut it.
No.
It is what we do every day with people that cuts it. You know, the waste, I'm going to say it, the wasted energy on reforming structures is pitiful. And I am really sorry that we have to do this restructuring piece on a regular basis, because it drives out the heart of really what we want to achieve, which is reform of the culture, reform of pathways, the ability to deliver best practice. Ed.
Thank you, Chair, and thank you, Richard, for your account, and good to see you again. And Steve, thank you for your heartfelt response. We will absolutely bring dementia back to this board, and Richard's indicated areas where we want to move forward some of your recommendations. But I'd like to just also recommend we take it to the Suffolk Health and Wellbeing Board. And the reason why I say that is this is a partnership issue, isn't it? Suffolk County Council, as well as the NHS, as well as the voluntary sector and others, need to all be behind this. And the concern I've got is I think there isn't a unified dementia strategy in Suffolk presently. So I think your call to unity and clarity of leadership, I think, will be a very good discussion to have at the Health and Wellbeing Board. So I'll invite Suffolk County Council to consider that as a future agenda item.
So thank you, Ed. So as we come to a close, way over time, but so important to have given this time. It's about actions, not platitudes, which I think you would agree, Richard. So we're committing to understand the holistic experience and the impact. This isn't about diagnoses or impacts of episodes of care. It's about impact in complexity and impact in making a difference and outcomes. It moves into translating that change in the context of people with people and inclusion, and how we do that in a coordinated fashion as public servants, but also with the public and with our voluntary sector as well. And there's a challenge in measuring what matters, not just what's reported. You know, that is a challenge for us all. What really matters? What can we measure? Who will be there to say, why is that measurement not moving or going the wrong way? And what are we going to do about it? And who is now going to do that? Is that a commitment the board's happy to accept? I don't see any dissent. Richard, you are very welcome to stay, pitch in if you wish. You're also welcome to say, God, get on with your meeting.
Well, I'd just like to thank you very much again for giving me the time, and I'm sorry if it's overrun, but I'm sincerely grateful. And to everybody, if there is some contribution I can make, very sincerely, please get in touch.
Thank you, and thank you for being with us. So at this point, and with all of those things in mind that this story has raised, it's time to move to Imran and Dean and Maddie and talk about item 7. Thank you.
Thank you, Mark. I'm gonna just very quickly kick us off, and then I'll let Dean get into the strategy piece, if that's all right, and Maddie can help as well. So just a very quick reminder. I can't help thinking of the parallels with Richard's story and inequalities, and the point that he's made around listening to people's voices and co-production. So if I remind everyone, back in June 2020, seemed like an absolute age ago, we had a What Are We Missing event, and the key 3 outcomes that came from that What Are We Missing event, were adoption of the 12 Doctors of the World recommendations around COVID, and these, remember, were system-wide, and we were fortunate to have lots of system leaders in that space, and a sort of universal agreement that they would be adopted. The second recommendation was the immediacy and support for those who were living in vulnerable circumstances, and what we could and would do to help those. And the final one is the key piece, and that was the system-wide adoption of a strategy, co-produced strategy, co-produced being the key word in all of this, with our communities to bring together a strategy around inequalities and levelling the playing field and achieving outcomes. And so we've been working on that ever since. There's been lots of great things done, the bus and all sorts, some of the courageous leadership that we've seen from Ed, with stepping outside of the recommendations around vaccinations and recognising the cultural differences and the needs that we had to tailor our services despite national recommendations, and dare I say, at great risk of criticism from the national teams, to do the right thing, not always do things the right way. And I think that's an absolutely key principle. So on page 3, I think it is, you can see the 7 principles. I've already talked about courageous leadership. Co-production comes up again, and this was absolutely key. This was about, as I said earlier to Richard, this is about the co-production being done truly. So from thought inception, right the way through the PDSA cycle, to also, and I deliberately use the word policing, to policing the outcomes and the actions and the processes we put in place to ensure that we are grounded in what we do, to ensure that what we hear is the impact on lived experience and the actual difference we're making on the ground, and not, as Mark has already said, that the numbers are going the right way or the wrong way. So connected learning, and of course the ICA is key in this, collaborative approaches, and the 80-20 rule, the concept of targeted universalism. If you focus on those who are in the worst positions with the worst outcomes, you bring everybody up, so you achieve your outcomes. But to do that, of course, you have to change the way you provide and commission services. And we've talked about disproportionate financial investment to ensure that the outcomes are what we achieve. It's not good enough to say everyone has the same level of access, because we know that's a fallacy. And then, of course, the key bits: culture change, a culture that stifles. We've heard already today. We've also heard Mark say a few times how culture can eat strategy for breakfast. So it really doesn't matter what it says on the paper. If we don't get on, and if we don't all change our culture and collectively align our incentives, and this is parallels with dementia all over again. We can, if we're not all agreeing what we need to do as a system, and we're not coordinated, we won't achieve the outcomes. supporting our colleagues and supporting and empowering them across the organisations. And of course, finally, the bit I've already talked about, which was collective strategic resource allocation. So this is the idea of differential financial investment to achieve our outcomes. Data, of course, is a challenge, and we've been working on the data with our colleagues, using the sort of vaccination as an incentive to start with that. So I'll skip through to the resources. I think we are moving into a space now, I can say positively, where we're beginning to start to recognise our system resource around this and how we can start to bring them together. And we're having conversations with public health around some of this as well. I'm going to hand over to Maddie, perhaps to talk us through a little bit about the current situation and some of the things we've done, and then hopefully we can give Dean a little bit on the next steps and the strategy work which he's been working on. Maddie.
Thank you, Imran. As I do, and I just want to also invite Fanwell, and I think if Louise is still with us, she may wish to contribute as well. So as you say, there's been a focus on, rightly, both on strategy development in co-production, but also on action, on delivery. And I think what we have seen is a really positive learning cycle of learning from the practical action into the strategy and moving around. So listed, and thank you to Louise for bringing this paper together, are the many actions which have taken place in collaboration over the last 12 months. And yes, indeed, where has that time gone? So working through the vaccination programme, working on very specific areas of inviting people to have conversation about very specific areas of health, from maternity through to end of life, and starting dialogue in order to understand conversation, what needs to be done differently, how do we need to work together in new ways, in new places, to achieve better outcomes, and doing it in a different way to achieve better outcomes in collaboration, in partnership. And again, I might have completed my whole Alliance paper before we get there, Mark, but I do just want to reflect as well in this moment that the Alliance values and the values and the approach, the principles underpinning the strategy which Imran has outlined just now are very tightly aligned, and that is so important. Because I think that begins to say that as a whole system, as a whole community of across Ipswich and East Suffolk, of individuals and of staff members across the Alliance, that we all want to try and make change in the same way. So I'll pass the baton on now to Dean, if I may.
Yes.
Whose name I can see, yeah.
Right. I mean, firstly, is probably to say thank you to the system partners, thank you to all the volunteers, and probably thank you for everyone for recognizing this as not only urgent, but important. There's a sort of a multiply misappropriated quote that you judge the greatness of a nation based on how it treats its most vulnerable, its most weak, its least heard. What struck me about Richard's story earlier is that it is only one story, and there are multiple stories that reflect exactly that. And Richard has the distinct advantage of being very eloquent and very dogged. But what I'd like to put to the board, that we have swathes and swathes of communities, swathes of people through no fault of their own, either through a protective characteristic or being part of a disadvantaged group, that are not as eloquent and forthright as Richard. And I think we do have a duty to outreach to them, to invite them into that co-production change to make us better, to change culture. Want to quickly move on to the why. the why is not only Richard's story, but it's some of the statistics that just floor us, irrespective of socioeconomic deprivation, education, or otherwise. A sort of a black woman is 5 times more likely to die in childbirth. Now, those are just statistics, but they're frightening when we think about it. And they're frightening not only for the moral duty that we have to do something, actually the very reason the NHS was created 70 years ago. They're also frightening because if we don't do anything about them, it will bankrupt our system, quite simply. If we don't do it if we don't co-produce, if we don't take a preventative strategy, if we don't take a co-produced system-wide strategy, quite simply by 2050, us as a nation will run out of money to treat these things at the crisis stage as opposed to the prevention stage. So again, reflecting on a lot of the themes Richard brought up, a lot of the themes that Imran brought up, it has to be data driven, it has to be evidence based. It has to go away from this zero-sum game that we think that by addressing one inequality or addressing one problem, let's say like dementia, that in some way we are taking away from other parts of the system. In actual fact, if we adopt a strategy that goes to those most in need, we uplift the entire system, we make it more cost effective. And again, it's not about the heroes like Richard. It's about culture. It's about systems. It's about strategy. And then lastly, this is tantamount to boiling the ocean, in that we have to address it at scale if culture is to change. And as Mark has said, it has to be putting the ladder up against the right building before we start climbing. We definitely need to look at the evidence. What works? How does it work? What is most cost effective? How do we measure sort of impact? But again, it all starts with leadership. And the unfortunate thing is that, like the bell curve that Steve alluded to earlier, there is a bell curve of leadership. At the extreme ends, they're the courageous leaderships, and then at the other end, they're the sandbagging leadership, and then the people who are just driven by whichever culture that they're within and don't try to change the culture that produces results for both staff, citizens, and patients. So what are the next steps? The next step has to be around co-production. It has to be around doing it in that the entirety of the PDSA cycle, not just workshops, not just PowerPoint presentations, but really engaging with those with lived experience and getting them as partners with us to deliver this. And lastly, to end on a probably dark note, if Marmot is anything to go by, there is a risk in the system that inequalities and all the work streams that we run will actually get worse post-COVID. The culture, the finance, the fact that we are in flux and in crisis means that there is every chance that if we don't grasp this nettle, that in actual fact, all of the statistics that Marmot looked at 10 years ago that are worse now will be worse in 10 years. So if we are going to do something about it, there has to be a bit where we say, okay, let's lean the ladder against the right building and let's persevere with evidence-based, impactful changes at scale. And I'll leave it there unless anybody else wants to contribute.
Thank you. Louise, did you want to add anything? There's no... In which case...
No, thanks, Mark.
Okay, thank you. Steve, and then Fanwell.
Sort of following on the theme of getting to help people as soon as possible and the efficiencies that are implicit in there, never mind the goodness of it. I didn't see anything specifically about refugees, Imran. Have I missed something in there?
It's all part of the work. It's catching and bringing in the groups that are not advantaged or are, you know, the phrase hard to reach, which we constantly rail against. It's not hard to reach, is it? It's seldom or never heard, and that's the challenge. So that there is a refugee group and they have been involved and just to a degree, but it's you know, all of it isn't enough, and this comes back to that point, Steve, about targeted universalism. And if we can get the systems right on the ground and make sure that, you know, our systems are such that they are proactively looking at and supporting groups, then we start to win. And of course, that, you know, I come back to it, and Jane is obviously sitting there listening to me. That, you know, that does require that differential investment. It really does. It's not good enough for us to say our services are open to everyone. They may well be, but actually, if they're not, you know, directly bringing in the groups that need it the most, and it comes back to Dean's point about inequalities in the health space, for example, around you know, if you get your disease 20 years earlier, you are going to need to be targeted 20 years earlier, because if you're not, the system is paying 20 years more and 20 years earlier on a cost that as Dean said, we can't afford, but we could help with proactively managing sooner. So the council are involved, and they're a key part of it.
Thanks, Imran.
Thank you. Panwell, and then Ed.
Thank you, Mark, and thank you for the presentation. I think reflecting on the things that have happened, as Imran is, properly done over the last year, I mean, we can actually see that a lot of the things that we are saying are challenges, you know, we can do something about it. We can achieve certain things. You look at the bus and what we've been able to do, that, you know, people from the Chinese community, worried about, you know, some of the discrimination that they are facing. Let's go to them. Let's do this. Let's go to the mosques and vaccinate people. Let's go to Latitude and try and vaccinate people there. These are things that are outside of the usual things that, we normally do, but we were brave enough and confident enough to step into those spaces. And actually, you can't help but reflect on the presentation that Richard just made, and thank you very much, Richard, for that. It's about, we talk a lot about person-centered or patient-centered support or care, but actually in terms of in practice, what does that actually look like? And some of the things that have been done during the course of this sort of what are we missing? I think there has been some very, very positive nuggets that we can take forward. The fear here is that these have been done as part of this pilot, but actually how do they fit into our day-to-day? How do they become the way that we do things going forward? And we do have spaces at the moment, our integrated neighborhood teams, we are going into the alliance spaces, we are with the ICS coming online. How do we make sure that the entire system picks up on some of the good things that have been done here and actually start to incorporate them into their, and the reason why I specifically mentioned the system is as part of this what are we missing journey, we would have meetings with communities, we talk to people, and you would have somebody who is saying, I am presenting to my GP because I'm experiencing discrimination and I'm stressed because of that. I'm losing my children, because of a divorce that I'm going through. I'm struggling with a lot of those things sit outside of this space, but we can only be able to solve them if we work as a system so that those problems are solved outside of, and those people don't sort of present because their issues have been. So we talk to people from the LGBT community, the traveler community. We talk to our faith leaders, and you find out that there are solutions in all those spaces. But this is stuff, as I said, and I want to reiterate this, is stuff that we had as part of this pilot. The next step is how do we embed this, right across the system and actually learn from this and make sure that, this becomes the norm going forward. And I think that is the challenge that all of us have got, moving forward. Thank you.
Ed.
Yeah, thank you. I mean, it struck me reading the paper how far this work's developed over the past, and it's a really sophisticated paper, so it's really impressive. And also the reflecting back on the first community event we had, where there was a lot of anger, and when we had one recently, the tone in the conversation was very different. So, you know, the community have felt an impact, a positive impact, which is great. But in terms of kind of where do we go from here, and what more do we need to do? I was just thinking about the terrible response to the black footballers following the Euros final, which has just sort of underscored the kind of racism we've got in our communities. And I'm wondering whether we're doing enough about anti-racism with our staff and with our communities, and whether we could give that a focus as we kind of continue to develop this work, because I think it's still a major concern and a deep-seated prejudice, unfortunately, that we have.
Thank you, Ed. And you never be able to look past the horizon if you don't actually start making a move towards it. So Imran, I can give you one last.
Yeah, sorry. Thank you, Mark. Sorry, I was just to say in response to Ed's point, the response to the racism, it's easy to do. You know, everyone gets equality training and race training, and you know, make all the statutory services. It is about how we show and the more of the what we do and how we work, really. And this is that key bit around aligning all of our incentives, aligning our focus around inequalities. And yeah, I'm sorry, final 5 seconds, Mark, is, you know, for us to achieve improved health outcomes, it goes right down to early years. It goes right down to the birth statistics that Dean's talked about. It goes down to our stop and search statistics. You know, it goes down to our employment statistics. It's all of that. And we can't do that on our own as a health sector. The whole system has to rally around. There has to be a collective, aligned, strategic approach to making sure that we're all doing this to achieve those outcomes. And you know, education, prison services, all of it. So it's a lot bigger than us just sort of maybe raising a flag saying we're not racist, we're going to do training. It's that whole big piece, and I think that's the bit the system needs to really own.
Lorna, can you do your piece in less than 5 seconds?
I can. Just as a comment, it's not just racism. We've also got to deal with degree of attitude to women, even within the Olympic Committee. Requiring the beach volleyball team to wear a bikini bottom is outrageous if they don't want to. You know, I mean, that is still everywhere around, and that includes all our communities, and not much is said about it at the moment, but it is definitely there. Yeah, misogyny. So, okay, thank you so much, team, for bringing these updates. I think it's important that it remains a standing item, because I think it is a barometer of winds of change, for the good things, not those the speech from which that comment came. So leaving Egypt and heading to the promised land, for all of you who've been on the One Team programme know that that's what we need to do, and people love remaining in Egypt. And that will only happen through continued leadership, the leadership that you're providing, the leadership that is out there in our communities that wants to see change for the better. We know that Marmot, Black and Beveridge, the reports remain the same. The challenges remain the same. They have not changed. They call them something different, but they are the same challenges. We should be confident because we have had a vaccination programme that demonstrates we can make a difference. We can find who's missing, who is easily missed. We just need to make the right efforts with the right ways. And there are opportunities out there, PHM programme for linked data to help us with the finding. And we should raise confidence that every contribution matters and can make a difference. And confidence will be raised further if people see that it does. And we should embrace the diversity, the challenges, people's experiences, good and bad, because actually we've all got one goal that matters, that is we want change for the better.
and we want to see things working in a better way. Public health, it's not about an absence of disease. It is about all the factors that give us health. It's our biological health, it's our psychological health, it's our health that we gain from having a community that is strong. And I think this programme represents a very strong barometer for that. So thank you for it, and we need to keep it there. Shall we move on into hopefully items that we can get through, crack on a bit quickly with, and regain some time. So Paul, over to you with the procurement.
Thanks, Mark. With that introduction, I'll keep it very brief. I'll take the paper as read, but just draw your attention to a couple of things. The Neurodevelopment Children's Services, positive outcome. Contract awards are in process. We're currently making sure that we coordinated services to make sure that they talk to each other, and that will move forward fairly quickly. Minor surgery, we're actually in moderation as we sit down today into the final stages, so we'll be able to bring some updates back on that. Pathology, service specification have now been agreed, and now we're moving to planning the process of the procurement itself. Essentially, the rest of the paper is really about update around legislation. We're still waiting for the final stage of legislation to come through. When we know that, we'll be able to make the relevant changes. And now that the boundary changes have been sort of resolved and clarified, we will now move in making sure we have some joined up thinking around procurement across the system, as we'd planned to do previously. And I'll stop there. Happy to answer any questions.
Thank you, Paul. Thanks for the succinctness. Any questions? No, in which case we note the paper. Thank you. And Maddie, back into the Alliance delivery plan.
Thank you very much, Mark. So we brought previously our review and reflection of the previous year's Alliance delivery plan, and presented to you now is our forward plan for this year. And as I've mentioned, in this plan, our vision and our mission and our values remain the same, and our mission is to work seamlessly together with you. And I think Richard's story and the strategy that Imran and Dean have now articulated really bring home why that is our mission and why it is something that we must keep as our driving force. The broad programmes of work presented in the plan also remain similar, but obviously each are progressing. Particularly, I want to pull out the work around mental health in our communities, around maternity, and I know it's been discussed previously by Lisa and presented, the work around urgent and emergency care, and ensuring that that is working well across our whole system, from prevention through to primary care with our pharmacy colleagues, as well as our GP practices, and into our acute settings, and of course the plan for elective care. The plan also presents as one small gap at the moment in relation to the digital milestones. So we have new leadership in that area, and they will be presented. I should say this is an ongoing and an iterative plan. It's not one that will be there this year, and just it is something we are working on and that we continue to work with. So there will be changes as our needs change, but also lays out then in the enabling programmes the work that we're doing around workforce, and Amanda is here, and also on estates, which I think is evolving at pace too. I think it's really important to mention that we are including now a very dedicated programme around personalised care, and the 6 facets of that. And also, and not yet mentioned, but will be reflected in the plan, is dedicated work on integrated quality. So we're going to bring that out following the most recent Alliance board meeting in a very clear way, to the very points that Lisa made in that meeting and has made today. And the last set of programmes relate to joining programmes, which include addressing inequality, but I mentioned earlier again our integrated neighbourhood teams in our 8 communities. And I wanted to just reference very specifically, Mark, I think about 3 years ago, you told me it was the year of the integrated neighbourhood team, and we drove forward a plan of action. And I think we said the same last year. We say the same again this year, and we will continue to do so because the work in our communities, in joining up to make, to enable one team of professionals to work with the community that they serve is so, so important. So I do think we will positively continue to say it's the year of the integrated neighbourhood team for at least the next 2 years until we are fully confident that the systems, the process, the leadership and the support that the Alliance wants to give is truly there. And I wanted specifically then also just to mention, obviously, one of our integrated neighbourhood teams is the coastal one, and Imran is a key leader within that. And I think it is opportune for that group, perhaps, Imran, you may wish to comment, but to have a really good look collectively together at the coastal communities report that has been published. So I know there's 4 key priorities in that plan at the moment, in our local plan, but there may be other things that are needed and wishing to be brought forward as a result of that publication. So last but not least, just to say that we have brought out in the plan this year 6 key outcomes and areas of focus that we will look at each and every board meeting. You'll see there's a great deal in this plan, but they relate to prevention, community services, thirdly, community mental health, addressing inequalities, COVID recovery, linked again. We have obviously come a long way in our journey in preventing COVID and to managing COVID, but it is really important that we keep very focused on that and our recovery. And last but not least, the very important underpinning action of creating one team across our alliance and in our integrated neighbourhood teams. So that, as I say, is the plan as it is today, but I do want to reiterate that it is a live plan, and I think quite rightly so. I'm really happy to take any questions, but it is our plan. I'm pleased to present it, but it is our plan as an alliance and has been brought together with many thanks to many of the colleagues here today. Thank you.
Thank you, Maddie. And it's absolutely right that it's an iterative process and remains open because, as our guest will know, plans never survive first contact with the enemy, and we have to be prepared to change the plans if things aren't working or the impacts aren't becoming evident. So thank you for that. So open to any questions on it, Lisa.
Maddie, I was lucky enough to attend the a celebration event for the first cohort of nursing associates that qualified across ESNEFT, NELFT and a number of providers, and talking to some of the qualifying NAs, their experiences cover all branches of nursing, so mental health, learning disability, acute and community as well, and children's services. And when I had to do a speech, so I was doing a bit of research earlier in the day, looking on HEE's website, and there are some amazing roles that other systems are putting in place to really maximise the use of this new role. So, for example, employed by mental health trusts and in reaching into, I know we've got a lot of those kind of models within mental health, but employed by learning disability services and in reaching to support into hospitals, and really working across the boundaries as well as some significant input into primary care. So I think it's a role that's really worth considering in your workforce plans for the Alliance.
Thanks, Lisa. And I think absolutely, and we have some such positive things to build on. in that regard. So I think the One Team programme dedicated to our nursing community is one. And I know it's been a really key focus, again, in the coastal community, but has also been very actively discussed in the northwest Ipswich area as to how we can just work across boundaries to meet patients' need and work as one nursing community and to think really laterally. So I know Amanda's put a comment in the chat, but I think progressing that will be a really, really welcome discussion. Thank you.
Yeah, and it really is about how we work together as one team, not who we're employed by. You know, those flags are important. You know, we need to feel connected to the organisation we work in, but it really is about, can we deliver that standard of care that we really came in to make a difference on? Any other hands up? In which case, thank you, Maddie, for the report. We note it, and we'll look forward to seeing those words become deeds. Thank you. Shall we move? I'm absolutely aware that we're way behind, and I'm hoping bladders are strong, but if they're not, can you tell me if we need 5 minutes? Oh, you're all strong today. So, integrated performance report. Can I hand over to Paul to lead us?
Yeah. Thanks, Mark. If I may, I'll do a couple of things. I'd like to spend just a couple of minutes talking about the new system oversight framework that's just been launched and give a bit of background to that, and then move on to some of the key focus and challenges that we've got in the IPR as we stand at the moment. So the new system oversight framework has just been published. It's gone through its final consultation. It gives us a number of key messages. It seeks to give clarity as to how NHSEI will monitor performance for systems and CCGs. It certainly reinforces system-led delivery of integration, building on a number of papers that have been recently published around operational framework, etc., and has some real resonance with the conversation we've just had around integrated alliance performance and integration of services. It does describe a much greater collaboration with national systems like CQC, and Lisa would step in that point and say absolutely CQC getting much more embedded in the way we do performance and look at outcomes as we move forward. The other important elements of the report is that it does replace special measures, which was always the go-to place if systems or organizations were not performing particularly well, as a bit of a punitive measure to a more of a system support structure. So it's actually called a recovery support program, which pulls in the NHSI elements in terms of support, in terms of transformation, etc., in the event that organization or system would require support in discussion with the system. So some nuanced changed in the approach to performance and outcomes. I think what also resonates with the conversation we've just had to this governing body is that it looks at the performance through a number of lenses, quality and outcomes and access to services, in terms of people, in terms of leadership and capability, preventing ill health, finance and use of resources, and what our local strategic priorities. And we might, for example, pick dementia as one of our local priorities in terms of system development, in terms of services. It's all underpinned by a number of KPIs, about latest count about 70 KPIs, but they're only KPIs, they're not intelligence. And I think moving forward, we have a real opportunity to think about, yes, in terms of the KPIs, in terms of what the tip of the iceberg looks like the performance, which are just to really start thinking about the intelligence that we manage and understand the outcomes of what we do in terms of healthcare. And I think, you know, Maddie's already articulated a lot of that in terms of the forward plan for the Alliance, and that's going to be absolutely key as we move forward. So I very much see the system oversight framework as a real opportunity to maybe to reset and really start to really think about, we not only got high-level key performance indicators, but start thinking about the intelligence that sits underneath it and where does accountability lies in terms of moving forward and in terms of harnessing partnership in the way we develop and improve services. So what I will do, if I would certainly circulate outside this meeting to members of the governing body the paper that's come out recently in terms of the system of that framework and KPIs. and in due course we'll bring back in terms of our approach around performance and how we might start to structure and think about performance, and our IPR report might need to change in response to that. Of course, this will all change in 2022-23 when CCG, SUT, BioRide and the new ICS, and we will expect some further guidance as we move forward. So we're essentially looking for 6 months interim, but things will be built on as move forward. So happy to pause there and answer any questions, but I think it's just to alert the governing body that things are changing in terms of performance framework. Okay,
thank you.
Just moving on to the report. Ed has already alluded to one of our biggest focus has been around elective recovery. And as you know, we're one of the accelerated sites, and indeed tomorrow we have one of our first meetings with the national team to review some of the learnings, and we'll certainly feedback as we move forward. In terms of the aspiration we set ourselves, it's fair to say I think we remain on target to hit 100% of threshold by the end of July. Moving swiftly on to October time to try and hit 120% of our threshold. We remain focused on achieving all the various gateways. That means that the income comes into the system, and we approach and do the right transformational elements that the gateways demand. In terms of impact, as we currently are, Ed's already alluded to the fact that when you look at our over 1 year of the waits, we've since I think May, we've seen a drop from about 7,000 patients to about slightly over 4,000 patients. So we are seeing a reduction in our long waiters. The numbers are still high, but we are seeing a significant reduction as we move forward. The problem being that we are still seeing an increase in our waiting list size. But what we need to point to is that if we hadn't done some things we've done, that waiting list would increase proportionally much quicker, and we've sort of, I think, slowed down our growth in waiting list. When you look at our over 53-week waits, and you look at our 92nd percentile, that's important as a measure, then we've dropped from about 53 weeks to about 44 weeks. So we are seeing a reduction in those, albeit there are still some challenges, some of our other specialties around orthopedics, for example, and maxillofacial surgery are one of the key areas where we got some really long waiters, and we need to address those with separate measures. But there are some risks, I think, around some of this. Our workforce, which we've talked about, and we need to count the good work we're doing around that workforce. We are seeing rising demand, particularly around emergency care. And again, that's a clear focus we need to be cited on, and we are doing some work around some of that. We are seeing some increases in our COVID cases in our hospitals, and it's unclear at the moment whether we're going to peak and drop or we're going to carry on growing, and that will be a challenge in terms of elective recovery. And finally, there has been in 6 months change in the funding arrangement around ERF, in so much that they've now altered the threshold at which point we get additional funding within the system, and we are currently looking to see what impact that means in terms of the first six months. And that's in part because a lot of systems across the country have recovered much quicker than was expected, and there is a clearly financial implication of that in terms of the way the thresholds were actually established. So that's essentially the elective element of that. We're progressing really well. It's hugely challenging, but making some really good progress. The only 2-3 areas I might pick out of the IPR report is a clear focus on mental health. And again, Richard might want to come into that conversation as he does his bit. There is also, as you'll notice within the report, some elements of CYP and community services we need to focus on, and we're currently working with the trust at the moment to come up with the plans, the remedial plans to address what is essentially issues around autism, predominantly as being the main issue around those services. So I think I'll stop there, and I'll take the rest of the report as read. I'm happy to try and answer any questions from my colleagues.
Okay, thank you. Any questions for Paul? Imran?
Hi, Paul. Thank you. Just to pick up on the elective issues and challenges around maxillofacial in particular, have we got any intelligence about whether that's related to some of the challenges in the core NHS dental services at the moment?
No
spillover.
No, it's not related to that. It's related to the fact that you've had it's a fragile service, sort of dependent on one consultant that's just retired. There's a real shortfall of maxillo-oral surgeons, and there has been a number of system-wide and regional conversations to see how we might plug that gap. And the trust are working really hard in terms of trying to source some additional support from a consultant level. I've asked for an urgent meeting with our regional colleague to see if we can find a regional solution to that, but it's not particularly related to the other dental issues.
I mean, I would just slightly challenge it, because at the moment what we're seeing on the ground is people unable to get a dental service, and so then the response, they come to the GPs, and the only thing we have left is, well, I can refer you to the hospital, but I don't know what they'll do for things like extractions and complex cases. So I think there possibly is something there, but I think be remiss of us not to challenge the national team.
I think what I'm saying, Brian, is the particular issue around the waiting list, long waiters, a specific issue to maxillofacial surgery, which are orthodontics, which is actually a combination of surgeon and dental consultant to take 14 years of training to be able to operate and do the things they do, as opposed to the real conversation around dental services, of which there is absolutely need current challenging our regional colleagues and the move in terms of what we do around dental services. And I'm splitting the two apart, if that makes sense.
Yeah, thank you.
Lorna.
Just quickly, one of the things that we've not been looking at over the last couple of years around COVID is the hospital mortality figures, the HSMR and the SHIMI. And I noticed from their May 2021 board meeting that those are beginning to creep up again. And I don't know, I think that's something we must absolutely on. It's all very well getting your operation in under 52 weeks, but if you don't make it, that's not where you want to be. So we must not ignore that, and that's got to come back into the integrated performance report for everybody to see. It is the final outcome for everything, and it's one of the most important measures. Although it's a quasi measure, it is a very important measure.
Thanks, Lorna. I think we've spoken about that before, haven't we, Lisa? Where are we looking at that within the system?
So I completely agree, Lorna, and I have asked the team to make sure that in the next pack it's really clear in there, because I think with everything else that's going on, for some reason it's slipped out of the pack. So I will make sure it's back. Okay,
thank you. I can ensure that action is there. Thank you, Joe. Steve?
No, I was just actually going to support what Lisa's just said. Please, can we have that back?
Yeah.
Thank you. Just a question about embedding inequalities principles into the elective recovery. Paul, where are we with
I believe there was a conversation at the last board meeting, which unfortunately I wasn't present at, so I'm not sure whether Ed, you're able to fill out, but essentially it is a major part of the work. There is a work stream that's been started through Susanna ICS team around inequality, and I believe she talked to it at the last elective board. Unfortunately, I wasn't there, so I've not caught up.
Yeah, I mean there is a need to be very intelligent about the elective recovery, so that things don't get worse on the back of everyone just being held in a line. Thank you. For the other directors, do you want to be very pertinent just around any specific questions that you want to ask of the board members that you've got here, and board members be pertinent about questions for the lead director? Lisa, over to you.
I haven't got any questions to ask. Is that what you meant, Mark? Was
just if there was anything within the presentation?
Okay. Well,
that needed a
bit. I wanted to pull out. So, I mean, obviously, from a quality perspective, demand and capacity and access to treatment, particularly on the cancer pathways, is of kind of paramount importance to the team. So. But we've already discussed that. We are just going through all the quality accounts from the providers. The providers have submitted to us their final draft of quality accounts, so we're just reviewing those before publication by the providers. We've talked before about maternity services in both ESNEFT and West Suffolk Hospital. So ESNEFT start today. Actually, today is their first Every Birth, Every Day programme, which will incorporate all the governance and oversight of maternity performance and improvement at ESNEFT and Nick Hume, the Chief Executive, is going to chair. COVID and infection control, you talked about hand washing in your introduction, Mark, and it's still something that is absolutely critical and something in all sectors we mustn't take our eyes off. Across our system, we've got 42 COVID positive patients in our 3 hospitals, 11 at Ipswich Hospital. So it is an area that we need to remain focused on, while alongside that making sure that the rest of the IPC agenda, so Clostridium difficile, E. coli, etc., is not losing the kind of focus. So yeah, we continue to work on that, and we're waiting for our objectives, is the term that's used for both our acute trusts, and the CCG will actually get a threshold of C. difficile objectives for the next year. And just kind of taking on the theme that Paul was saying, but also reflecting back on Richard's story at the beginning around quality and how we understand patient, public, citizen experience. We're just starting to look at what will the quality governance look like in an ICS and also at alliance level going forward. And the framework that we will be building will be looking at what does good and outstanding care and services look like within systems across different organisations, services and levels of delivery. So we'll really kind of provide that foundation for how do we understand system working around quality, and how do we understand what people's lives and how people experience the services that as a partnership we want to provide. So that's a massive piece of work that we need to co-produce with all our services and with our public. So yeah, that's really next on the agenda. But other than that, I'm happy to take any questions. Thank you.
Thank you, Paul.
Yes, thank you. It's just to say on the cancer bit, both trusts have put in recovery trajectories and are saying to us they're quite confident they will meet this trajectory in terms of recovery at specialty level, so quite granular detail. The other thing I omitted to say around the elective recovery, we are monitoring our long waiters around cancer, and the general trend has been a reduction in long waiters around cancer patients. Having said that, upper and lower GI appears to be a bit of a challenge with SNF at the moment. We are looking at that as we speak.
Thank you. Graham?
Yeah, thanks, Mark. Lisa, I've just got 2 quick questions. One's on the special education needs service, and there was a lot of concern from the carers and parents of that service, and I think there was an independent review going to take place. And secondly, we also recently had issues with maternity services at Colchester Hospital. If you could just say a bit about what improvements we've made there and what we're doing. Thanks very much.
Sorry, on mute. So Suffolk County Council have commissioned an independent review following some significant feedback from families. So they've commissioned that review into understanding the experience of families from both an education and social care provision, which we've been involved in understanding the terms of reference and supporting them, but health services themselves aren't going to be reviewed as part of that. But we think it's a really helpful and proactive step from Suffolk County Council to commission an independent review, so look forward to receiving that. From the perspective of maternity at Colchester, I think it's fair to say that SNF's maternity services on a whole are still in a place where really continued oversight is required. So the workforce issues that they have, which, as we know, is a national problem for midwives, is still there. We had at clinical scrutiny, Giles Thorpe, the Director of Nursing, came to clinical scrutiny and presented the maternity improvement plan, which was incredibly helpful. it's a robust plan which will go through the governance of every birth every day programme board, of which the first meeting is this afternoon. But there's a lot of work to do. There's a lot of work to do around making sure that the right leadership is there, and the new director of midwifery starts in 5 weeks. So we're really looking forward to welcoming her. They're looking at some changes in structure, possibly to the midwifery leadership, because they've been out to advert twice for the head of midwifery and haven't been successful on the Ipswich site. So it's a really comprehensive programme, Graham, that is going to take a while to deliver as well. And there's a very punishing transformation programme within maternity services, which is absolutely right, following Ockenden and the Better Births agenda. But it's sometimes difficult to kind of work on a massive programme of transformation and quality improvement when actually you need to focus internally on some of your own fundamental quality issues. And I think doing all that is incredibly testing for the team. But we have confidence in their plans, so we're just supporting them in the delivery of that.
Right. Thanks very much.
Thank you. Any other questions for Lisa? Then Jane, shall we talk finance?
We can, and I'm taking your hints, Mark, to be brief. So because we had a detailed financial performance committee last week where I went through a lot of the detail on the finances, but in terms of the headlines we submitted, we are working in a 6-month period where we've received our allocations for, so we are looking at the first half of this financial year, and for that we submitted a on-balance plan, and we have reported at month 3 that we are achieving the on-balance plan. But as I reported to the Finance Committee, it is incredibly tight this year, and that's partly down to the way that CCGs are financed, and the fact that the majority of the funding that we receive is already earmarked to pass on to providers. So of those areas that the CCG looks at directly, we are seeing pressures, particularly within CHC, continuing healthcare. However, we do have non-recurrent funding that we can use to offset that at the moment. So we are predicting that we will achieve our balance plan for the first half of the year, but we're awaiting news on what will happen in the second half of the year, which we're expecting to come out around about September time. And we're not expecting a huge amount of change, so it will continue to be tight this year, and we'll need to keep a real focus on financial risks.
Thank you. Any questions for Jane on that? No, thank you. Richard?
Thanks, Mark. Overall, just to say that we're expecting planning guidance to hit us in the next 6 weeks for H2, so the second half of the financial year. So we'll be going through a further exercise to set out our plans in some detail. And then we've also got the joy of doing our next financial year planning as well at some point. So there'll be plenty of opportunity for lots of planning in terms of how we're proceeding with our work. In terms of actually what we're doing here and now, just some headlines. Paul's already covered the majority of the elective care work. Just to touch on the fact that we've now set up musculoskeletal and eye care programmes across the integrated care system. So effectively to look across the 3 place areas, including Ipswich and East, what more might we do at scale to improve those models and pathways of care? And similarly, we're looking at the 27 or 28 high volume, low complexity pathways that the national team have set out where there's improvements to be made. So we should see some progress on both of those areas fairly soon. On cancer, the main 2 areas just to note is a focus on the breast pathway. So we're particularly challenged in the ESNEF part of the integrated care system. We had a really good workshop with system colleagues across the region. And actually, we invited the Nottingham team to come in and talk about the work that they've done in setting up a different model. We've got an in-depth meeting with the lead for that, Professor Robertson. I think it's this week, and we're looking to potentially move to adopt that. Integrated care, just to touch on the challenges we're experiencing across the board on urgent emergency care demand. There's a workshop taking place tomorrow across the integrated care system to look at what different ideas, innovations we might take to try and address some of that pressure. On children's, we've got the outline mental health model agreed and the specifications. There's my dogs in the background, apologies. And we're now very much into the demand and capacity modelling and expected to get that concluded fairly rapidly. We've also just concluded a review of community paediatrics, linking to Paul's point, and we'll be bringing the report for that through and recommendations through to the September Alliance Board and Executive. And mental health, I'll be bringing back more of a comprehensive report to the September governing body with your agreement, Mark. So I'll leave it there. Thank you.
Thank you. And in terms of urgent and emergency care, we must remember that quite a significant amount of urgent and emergency care is delivered in primary care. I think something approaching 35% of our calls are new problems on a daily basis. So when we translate that into the quantity of work that is done in primary care and the demand that has increased, I think one of our major practices reported a 43% increase in call volume to their practice over I don't know, since Easter or something, on a daily basis, and translate that into the urgent and emergency care. We've got to understand just what the quantity of that is out there, and it isn't just about the increase within the the emergency department and GP streaming. So we do need to be very, very cognizant of where is it that we need to put support in terms of the whole picture, not just what happens at the front door of a hospital. So I'm just putting that out there. Maddie, you wanted to talk about primary care.
Thank you. So as we don't have a primary care commissioning committee this afternoon, there's just a couple of points I do want to bring to the governing body's attention. So you will see that we are slowly increasing our screening and our health check rates. But as we've discussed before, that's incredibly positive. But obviously critical to that too is the care post-diagnosis, as we've also discussed today. I also just wanted to highlight that the patient satisfaction surveys were published recently, and Ipswich and East Suffolk was at 86.9% overall for the experience, as compared with 82.9% across the whole of England. So I think in the context that we face, that is very positive to report. I must also mention, in terms of prescribing, there's clearly a great deal that we need to do to ensure that we are focused on the budget. I think that we did do absolutely the right things in terms of prescribing during the COVID period, but we are looking across the whole ICS at how we work together on the next steps of that. And then I was going to say the points that you've already said, Mark, with regard to demand, so I'll leave it right there. Thank you.
Thank you. So any other questions for Richard or Maddie? Have I missed anybody out? Great. Okay, in which case, shall we move through with speed and alacrity into governing body assurance framework? Graham, anything that you wished to highlight to us?
No, I mean, Mark, the key points are in paragraph 2, but there is one new risk on there, which is risk 57, which is to do with the white paper. And I think Ed's already touched on that, and we know what we're doing with that, don't we? So other than that, I got no other comments to make. Okay, any queries or comments from members of the board about the risk register? In which case, thank you. Shall we move on to freedom of information, Amanda?
Thank you very much, Chair.
Sorry.
I just wanted to confirm that if maternity services were on the risk register, because I can't just find it, so I just wanted to confirm that from Lisa.
Yes, it's been worked up, Aisha. I think it's just going through the governance and didn't quite make it to this cut.
Okay, thank you, Lisa.
I think it's on the departmental risk register but it's not made it up to the GBAF yet.
Okay, thank you.
Thanks. So Amanda, Freedom of Information.
Thank you very much, Chair. So here we have our regular report for the first 6 months of this calendar year. And as members will see, we continue to receive on average about 20 requests per month, which is in keeping with previous reports. All are answered within 20 days, which is very good news. And in terms of the type of information requested, it relates mainly to commissioning. We've had very few questions on COVID, but where we have been asked from members of the public, they have been mainly around numbers administered and the types of vaccine given. So really a pretty standard update in terms of FOI, but very happy to take any questions.
Any queries? Thank you. We'll receive and note that. Thank you. And in which case, on to the minutes of the meetings, which are all there to receive and endorse. Anyone got any queries about those? Great. In which case, they're endorsed. So on to date and time of future governing. Have I got 5 minutes back on track? Well, it must be down to you guys. Thank you for that. Date and time of the next governing body meeting, Tuesday, the 28th of September at 9 o'clock. And we now have time for questions from our public. Joe, you circulated questions in advance that have been sent in to us. Have we received any others that we're aware of? Or Simon?
No, I just sent you one more during the meeting from Mr. Dooley. Did you get that one? There was an additional one.
Okay, well, I'm sure.
We've got about 8 questions here. I've got them all here. Do you want me to go through each of them one by one?
Yes, by all means.
Okay, so the first question from Anthony Dooley. My question, he says, is in relation to the staffing difficulties faced in trying to implement new ways of working in antenatal care. Does the CCG consider that a 15% pay increase for NHS staff would help to address this staffing issue?
Lisa.
Thank you, Anthony. I'm so tempted to say yes, but I won't. I think it's much more deep-rooted than that, actually, than the money. I think it's about making sure we've got the workforce numbers right, and I think it's about culture and making sure that we have the culture and the leadership and the team approach, all the things that Richard talked about actually in his story at the very beginning. I think that's probably more important than a 15% increase to retain our midwives and to attract more midwives into the service. So yes, I mean 15% would be lovely, but I won't. I think that's probably quite unlikely.
Okay, yes, there are 3 things that I've experienced as a GP and as a medical person working with clinical teams and everyone who is supported by a clinical team. And 3 things that people want: they want to feel in control of their work-life balance. They want to feel in control of the standard of care that they can deliver to the people who are in front of them. And those who are around them, and they want to feel rewarded. And rewarded is money, but it's also more than that. It's about being able to feel that the job that they've done that day, the experience they've had, the experience they've been able to give others has been the right one. And if we can get a balance of those 3 things, then I think that will do more to meet the needs of people wanting to do the best that they can as a consequence. Simon, number 2.
Okay, number 2 then from Anthony Dooley. In the light of the fact that the BMA has come out against the proposals contained within the NHS bill that we described as the corporate takeover of the NHS. Do the members of the CCG individually support the stance of the BMA?
Anyone want to?
I mean, I don't know quite what the BMA have said and responded to, because there's a lot of detail in the bill, but I wouldn't describe it as a corporate takeover of the NHS, because the majority of the CCG resources will be moving into the new NHS bodies. So for us, it's much more about continuity. So I personally wouldn't support that statement, but others may have different views.
I think somewhere around, is it 7 to 8% of the budget is spent in non-public sector bodies, and I don't think that's. I think that did increase from the 2012. I think I read somewhere it went from about 5% to 7.5%. So that, you know, it's a 50% increase if you want to see it that way. I think the 2012 bill also had that writ large and said about it, but it hasn't come to pass. I think one of the issues that the BMA has mainly made a question of is the power grab, as it's quoted by the Secretary of State, in terms of decision making over anything, and with great power comes great responsibility, and goes back to the Nolan principles. It goes back to the leadership. It goes back to the humility that we may and should have in terms of addressing the problems a system is trying to meet. Anyone else got anything to say on that? Question three then, Simon.
Okay, the third question from Anthony Dooley. Further to the legal instruction by NHS England for GPs to make available patients' confidential data to NHS Digital without the consent of patients, in light of Joe Churchill's letter that contained a reference to engaging with the public on this matter, would not a positive response to my previous request to the Chief Executive to send a statement to accompany recent headlines have been an indicator of good faith on the part of the CCG and in the spirit of co-production?
Ed?
I mean, I think nationally they've agreed to pause those plans, haven't they? So that they moved the opt-out date to September, and I think they've now paused that. So I think whilst those plans are being reviewed, we'll keep a close eye on that, and once we're clear on where the government want to go with it, we'll take a view on the response we want to make. But obviously we will support our patients to be aware of the GDPR requirements, and we'll give them, we'll communicate well on it. And if we're not communicating well, do respond to us, Anthony.
And there's been a lot of commentary about this that I've read in newspapers around the benefits and not that could accrue as a consequence of doing this. And the question is, where are those benefits realised, and who is benefiting as a consequence of those benefit realisations? And which again comes back to the trust in the decision-making process. I think it is imperative that these decisions are made in open and transparent ways, that the intent is selfless and it is objective. And I think that if it were explained in a way that where people could see that this is not about understanding their personal data personally, it is about understanding personal data in the context of the population and the benefit that can accrue as a consequence of that, I think there would probably be much more support and confidence in taking this approach. And in population health management, we are taking this approach locally and trying to build our capability and capacity to be able to do the right thing, to be able to find where differential investment would really make a difference. And if we think that's important, then sharing our data with confidence that it is about that intention and not about somebody running off with it and making a packet on the side, then I think we should have confidence in how that data can benefit us all as a consequence. Any other comments on that one from anyone? Okay, Simon, next.
Okay, the fourth question from Anthony Dooley. We all remember the Vote Leave bus that contained the statement that in voting to leave the EU, £500 million a day would be available for the NHS. Given that more than 6 months have passed since leaving the EU, could the CCG inform us how much of that colossal sum has been made available to the CCG to date?
Jane, give us the good news.
Yes, thank you. I think it's almost impossible to tell, unfortunately, at the moment, because we've been in the emergency financial measures for the last 18 months. So we haven't had our normal system of allocations, etc. And in fact, if anything, you could say that for the first 6 months of last year, because of COVID, money was no object around the NHS. So we haven't resumed back to our normal allocations, our long-term plan allocations, but as far as we know, there has been nothing so far that has been additionally provided specifically from the impacts of EU withdrawal. But I will watch this space and let you know as and when we hear anything.
Thank you. Next one, Simon.
Next one is question 5. In light of the insulting 3% pay adjustment to NHS staff and our understanding that this will have to be financed from existing resource allocation, what will be the likely impact on services should the local health economy have to self-finance the pay offer?
Jane?
Yeah, thank you. This one, again, I'm going to not give you a definitive answer on, but we, as I said in the finance section of the report, we are awaiting our allocations for the second half of the year, and we have been informed by Department of Health and Social Care that we should expect those to include monies to pay for the pay award, as and when that was announced. That we were told that just before the announcement was made. Obviously, 3% is a significant impact. It's mainly on our providers, but also on the CCGs. As a rough rule of thumb, we spend around about £1 billion on pay within the NHS in our patch. So 3% would obviously be fairly significant, tens of millions, should we need to find that within the resources that we've already got, which, as I said in the finance paper, are extremely tight. However, we have been given assurances by the national team that we should receive the funding for that.
Okay, so one to bear in mind for a future meeting, perhaps once we've got some certainty around allocations, Jane. Okay, thank you. Simon.
Okay, the sixth question from Anthony Dooley. Does the CCG agree with the new Secretary of State for Health and Social Care that people should not cower in the face of the pandemic, and whether the Director of Public Health's 3 C's advice to residents capitulates to government policy, which is that many young people in particular have become and will become infected by the Johnson variant as a result of herd immunity? Is that compatible with the aims of Health and Wellbeing Board, on which the Chief Executive sits as Vice Chair?
Ed.
Thank you. So reading the papers, I saw that the Secretary of State had apologised for that language he used. So I think that answers that part of your question. On the Director of Public Health, I can't remember all of the 3 C's, but the one I remember, the 2 I remember, was around being cautious and courteous to others, which I think is a perfectly reasonable direction to the people of Suffolk, in that we're not out of the pandemic and we need to be cautious. So I don't agree with the conclusion that you've reached that he's capitulated to government policy.
No, and certainly in our practice practices and in our hospitals, we are still wishing to see that cautious approach as we progress, because of the hands face space, being kind to each other, still remains an important facet. The pandemic has not been declared over. Next question.
Question number 7 from Anthony Dooley. Having raised with the Chief Executive that tweets from the CCG and Suffolk County Council claimed that if people had 2 coronavirus jabs, they would then have full protection, when will the CCG and its partner, Suffolk County Council, put out a statement in all media and in all formats apologising for the misinformation in those tweets and repeat a warning, especially given the end of legal restrictions, that none of us are fully protected?
I think, Simon, you said you would answer that question. Yep. Anthony, thank you for raising it. The language in the tweet was inappropriate.
Thank you very much, Anthony. This was a retweet. We have now removed the retweet from our feed, and all of the materials that we have issued do make it clear that 2 jabs will give you the best possible protection, and we will tweet this message so it's really clear. So hopefully that answers your question there. Shall I move on to number 8? Question 8 from Anthony then, Anthony Dooley. I am yet to find out from Councillor Hicks and Stuart Keeble why the recent Health and Wellbeing Board meeting was held at Wearstead, particularly as legal restrictions were still in place, yet your meeting is being held online as a way of protecting the public. I presume because legal restrictions have been removed on so-called Freedom Day. Could you clarify this, please?
So this relates to the rules that all councils are under, that formal public meetings now have to be held in public. I think they organised a meeting at Worsted Park just because of the size of the venue we needed to socially distance, I think around 30 people around a table. So that was the reason for that. CCGs aren't required to meet physically in public, so we're able to meet virtually as we've done today, which we think is a better way forward given the current state of the pandemic.
Okay, and the last question from Anthony Dooley. I'm amazed at the talk about changing culture. When a doctor raised the concern at West Suffolk Hospital about poor practice, the management's response was to find out the source, not to acknowledge the issue and address it. Was the action of the doctor not an example of changing culture?
Anyone want to respond? I mean, I would start by saying that we do have a duty of care to patients where we have an issue and need to raise it, and there are whistleblowing policies. I don't really like the word whistleblowing, because raising concerns isn't always about whistleblowing. It's about constantly having a culture that allows concerns not only to be raised, but to do something about them. I'm not sure why I would be amazed at talking about culture change, because I think it is really important. And we shouldn't be accepting practices that stifle positive changes in culture. As our guest alluded to, we risk constantly strangling the chance to change positively as a consequence of knowing if there is something going on. I don't particularly want to talk about the specifics of that case. It's going through due process at the moment, which I'm sure Ed is more versed on than I. But I think that the culture of raising concern, the culture of being able to change things for the better is one that we shouldn't be amazed about. It should be something that we expect.
Yeah, and I would agree with all of those comments, Mark. And I think there's been a lot of learning from what's happened at West Suffolk, and the review report, which will be published sometime in the near future, will, I think, generate more learning too. So we can come back to that, Anthony, at a later point.
Thank you. Simon.
And there's one more question, this time from Mike Hope. He writes, my question for the next Ipswich and East Suffolk CCG meeting is to ask Ed Garrett, as Chief Executive of both CCGs in the emerging ICS, about whether he can categorically state that all people seeking COVID vaccinations have been offered it, regardless of their residency status. This question comes off the back of news from other parts of England that some GP practices have refused to vaccinate some refugees, asylum seekers and migrants because they lack the right documentation, despite NHS England clearly stating that all those seeking vaccination are to be offered it regardless of residency status.
Thank you, Simon. So I've replied to Mike in detail and in depth to his question. But in essence, the answer is yes, we've offered the vaccine to everyone. And in my email, I've set out a number of examples how we've worked with different cohorts of the population.
Thank you.
And those were all the questions.
Thank you very much. Thank you all for coming. Thank you to our guest, Richard, for his help to us, his offer of help to us. Thank you all for your attention, and thank you to our members of the public who are out there watching, either live or later at their convenience. And we'll meet again in September. We do have a part 2, which I think is at 12:30. So you have a short break before we meet again then. So as we have a guest with some